Good evening, everyone. This is Sripriya welcoming you to our 14th session of Foundation course in Palliative Medicine. Today, we are going to go through one of the most interesting topics, the psychosocial aspects in palliative care. And we have a very experienced faculty to walk us through the same. It is my privilege to welcome Ms. Mukta Dhavalikar. Sorry if I am pronouncing the name wrong, ma'am. For walking us through the session today. She is an RCA registered clinical psychologist. She had completed her MPhil in clinical psychology from Amrita Institute of Medical Sciences, Cochin. Currently, she runs her own practice in Goa by the name of Manavet Consultant and serves as the clinical psychologist at Vilasa Center for Palliative Care for the past 3 years. So, hoping that her vast experience in this particular field will help us have more light on your careers. Mukta ma'am, it is over to you.
Hello. Am I audible?
Very feeble, I believe, ma'am.
Okay, just a second. Is it better now?
Yes.
Okay, all right. Yes, so let me just start my presentation. You can see it, right?
Yes, ma'am. Perfect.
Oh, yeah, yes. So yes, first of all, a very big thank you to Pallium India for this wonderful opportunity given to me once again to interact with all of you. And a thank you to all of you as well for stepping into this field, which is so close to my heart. I understand that all of you are doctors who are new to the palliative care setting, right?
Yes, ma'am. Mostly, some of them will be having some kind of experience, like.
Okay, fine, yes. So, but that means all of them have been introduced to the basics of what is palliative care. You have some idea about what palliative care is, right? So could someone tell me what they know about it, what they think is palliative care? It's not an exam. I'm not judging you. I just want to know what is your understanding so that I can take it from there. Perfectly okay to give imperfect answers. So if somebody could volunteer and let us know what they think is palliative care.
Request participants to unmute themselves and kindly respond to the faculty.
Hello.
Yes.
Yes, palliative care aims at improving the quality of life of the patient and the family, and takes care of symptoms, and it also includes bereavement counseling.
Okay, yes.
Non-malignant conditions.
Yes. Okay, great. So Aisha ma'am, I think has covered a lot of the factors which come in our definition. So if we actually had to look at a definition here, given by WHO, we could say that palliative care is treatment which is aimed at improving quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, through correct assessment, and treatment of pain and other problems. Now, may these problems be physical, psychosocial, or spiritual. Right? So let's move away from this definition a little bit. And instead of theoretically understanding this, let's look at what we do on a day-to-day basis. Even without actively working in palliative care settings, working as a medical professional, you would have all witnessed people suffering, right? So what is it that you see? Is it just physical pain? What's the first thing you notice about a person who is suffering from an illness When you go to the hospital, you look around your waiting rooms or OPDs, what do you see?
Sadness. They are most times
Sadness.
sad.
Yes, absolutely. Yes. Yes.
Anxious faces.
Anxious faces, absolutely. So you basically see that they're unhappy. They look emotionally distressed. Some of them are crying. Some of them look scared. Some are restless, pacing up and down. And now imagine that it's an illness which is either degenerative, terminal, or causing severe pain. Yeah. And what do you think will happen to this person? So we realize that this patient is not only in physical pain and distress, there is also a component of psychological, social, and spiritual distress, right? And the quality of life is also really hampered. They're unable to do things that they once did so efficiently, things which added value to their life. These might seem like small things, but looked at it in the context of that illness, these are really the things which added value to their life, like earning for themselves and their loved ones, feeling good, mind and body, being able to do things that they loved, going out, playing, spending time with friends, enjoying eating good food. So much is lost or reduced. And palliative care is all about looking into these aspects along with pain and symptom management. So we talk about holistic whole person care, we talk about psychological well-being, spiritual well-being, emotional well-being, social well-being. And apart from the fact that illness affects well-being in all these areas, we should also not forget that the mind-body connection is a two-way connection. So just the way body affects the mind and mind also affects the body. We have seen research shows that emotional distress often exacerbates people's pain perceptions. So, and even disease trajectories at times. So all these other types of well-being apart from physical well-being will have an impact on the physical well-being of the patient. Right. So, and again, the caring is not only limited to the patient per se, as Aisha ma'am had already said. We also look at the caregivers. We also look at the family. Why? Why is the family the unit of care? What do you think? Basically, patients' symptoms and families coping with the illness are not really unrelated to each other. Both need to be addressed because that is healthier for both. Let's say, for example, a life-threatening diagnosis. Is it traumatic for a 37-year-old woman if she gets a diagnosis of, let's say, some terminal illness? Would you consider that it's traumatic for her, right? So would it also be equally traumatic for her 40-year-old husband? That, his wife is undergoing something like this. Also her 10-year-old child, right? And her aging mother. So if you go to see the emotional and physical resources, right, from money to savings, to the resilience and the ability to deal with stress, all these different kinds of resources of the entire family are threatened. It's a family crisis. It's not an individual crisis that you are dealing with. The patient is not isolated. They are a part of a family system. So that patient's psychosocial physical health is going to impact the family and vice versa. So you might have seen patients with terminal illnesses who have spouses suffering from depression or some other psychosomatic symptoms, but their health also deteriorates. And that is mainly why we need to look at the entire family unit when we are caring for the patient. Also, the losses which are suffered by the patient are also losses suffered by the family. Let's say, for example, patient's loss of role as the head of the family is also the family's loss of a primary breadwinner. Yes, so illness is impacting the entire family. In addition, there is, of course, we cannot dismiss the exhaustion, the stress which comes with caregiver duties, often leading to burnout, compassion fatigue, guilt. Our role here is to help them vent it out, to give them some relief from it. In In addition, due to the inadequate understanding about what palliative care is, even a referral to a palliative care service is experienced as a crisis many a times. So we have had patients in the LASA where I consult, where the patients were brought in by their sons and their daughters, and then they had to really face outrage from their relatives, where they were blamed with words like, you're taking him there to die, you're giving up on him, you're being negligent, you're not fulfilling your duties as a son or daughter, you're being cruel. So basically, people's understanding of what palliative care is also affects the entire family. So family-centered care, where the healthcare team, the patients, and their families have an equal partnership, is the basis of the work that we do. Now, you might agree with me on this, that it's not only a physical illness, there are other psychosocial issues, and that it's the entire family which is facing these issues. But some of you might have a question about why you need to know about it. If you're not a psychologist or a social worker or a psychiatrist, what would you do in this particular area? You need to know about this so that you can do the needful, which is possible for you. Since it's a multidisciplinary team, we all need to be aware of the possible issues that can arise so that we identify, assess, we do our bit to support, and if needed, refer to a specialist. There is a psychosocial dimension to the work of all professionals who are involved in palliative care, and understanding this will definitely strengthen the practice of any professional working in this field, regardless of your specialization. So even if you can't actively do anything to help relieve their emotional sufferings, you can always definitely listen. And how to listen is, I think it's something that might have already been covered in if you have had a session on communication skills, or if you would be having one in the future. So never underestimate the therapeutic value of listening empathetically to the story that your patient is bringing in. Because here you need not be able to hand over solutions to them, just being able to give them a space where they are heard, that is incredibly healing. Now, when I say that, let's not confuse healing with a cure. We are not talking about a cure. Cure is about getting rid of the illness, removing it completely. Healing, on the other hand, is an acceptance of change, looking at themselves in a different light, not as sufferers, where the patient starts to seek personal resources to facilitate that change, to look inside and to find the strength to deal with what is happening. And that is what I mean by healing, and you can promote it in a big way. So let's first look at what are these psychosocial, spiritual issues that can arise in this context, so that you'll be able to identify them in your patients. Along with that, let's also look at what can be done to assess the extent of distress and to treat it. It's not really possible to separate out these issues into psychological, social, and spiritual. We can only do it up to an extent because these are pretty much overlapping issues. So when we're discussing a particular issue, it will have psychological aspects. It will also have social aspects and spiritual aspects in varying degrees, right? So the first thing we're going to look at is communication. One of the first issues that comes up is communication issues, right from breaking the bad news to the patient and the family. I won't go into the details of it because I'm sure you'll be having a separate session on communication altogether. So instead of getting into the protocols of how to break bad news and all of that, I would like to draw your attention to what happens when there is miscommunication about the illness and miscommunication within the family. When we do this hurriedly, when the family is not given proper idea about what is exactly going to happen, it can cause further problems, arguing, non-compliance with treatment if people have misconceptions about the diagnosis, the prognosis, and the treatment. So supporting and educating the family is really vital. It is important that they have an adequate understanding of the illness and the expected process. It's important that we give enough time to address everyone's concerns about it and to help them communicate clearly. Speaking of communication issues within the family, Even the most functional families find it difficult to talk openly about it. Collusion is something that we very often see in palliative care settings. People naturally tend to hide feelings to protect family members from feeling hurt, etc. So they might either hide their distress from each other or hide the news itself in the first place, especially from children. Before I began practicing, during my training, a major part of my work was with pediatric cancer patients. These were little children suffering from cancer. I have seen innumerable such parents who, I really don't remember coming across a single person who didn't hide their own pain and sadness and fear from their child. They did it to stay strong for their child. But the problem here is children sense hidden restlessness and anxiety. That their parents are hiding something from them is even more unsettling and scary for them rather than knowing the truth. So thus usually there is no choice about whether or not to tell children about these illnesses, because one, they read emotions around them. They notice adults talking in hushed voices and notice adults quickly wiping tears and all of that. They also respond to body language. They can see sympathy in people's eyes. And thirdly, they're definitely aware of changes in their routine. They realize that they were told mama went to hospital to see the doctor, but she's not back yet. They realize that mama doesn't drop me to school anymore, that my auntie packs my tiffin. So there is no point in hiding things. Honest, open communication in a way that children understand is the key. And we need to help parents see that if they are misguided in their attempts to protect their children from harm. So one of our major roles is in facilitating open communication and expression between members and between families and treating teams. Okay, the second issue which we come across is predominantly social in nature, loss. So the loss is experienced, it's not just loss of life that we're talking about. Loss is experienced by patients in relation to their social world, are concerned with the engagement with the world outside home, with their roles and relationships within the family as well as outside the family. So we talk about, when we talk about loss, we talk about a loss of future, loss of identity or loss of role, loss of social engagements, and loss of self-esteem. For example, the loss of my job role as a teacher is associated with so many things. A loss of financial independence, loss of a meaningful contribution to society, a loss of living according to my values, loss of my confidence in my role. So much of our self-concept is linked to who we are and what we do in a social context. So that is why all these things become very important. Because as mobility and energies decline, it becomes harder for patients to participate in social events and to maintain friendships which were built on shared activities and interests. And social isolation is a frequent source of social pain for both the patient as well as the carer. In some cases, it is possible to an extent to get them to meet friends or colleagues, to have meaningful interactions with them. But for some, the change in the way they feel about themselves and their declining functioning creates such a big gap between their past social engagements and their present limitations which come with the conditions, that here the only solution could be that we get them to participate in new social groups altogether instead of trying to integrate back into old groups. When I say new social groups, I mean cancer support groups, such kinds of groups where they can both learn how others deal with a changed identity, they can compare their own situations, and they can continue to feel that they can make a contribution in some way. Especially with patients who say that they have stopped talking to people because they hate the look of sympathy or pity in their eyes. They, when they see that people hesitate in sharing good news, that they don't talk about anything else but treatments and illness and their conditions, So such kinds of experiences where they get to meet people who are in the same boat as them and are not showing sympathy or pity, such kinds of experiences could lead to a feeling of belongingness. Whereas on the other hand, trying to integrate them into their older social groups can lead to a feeling of being left out, being unable to connect with those who are unaffected and going about their previous routine hunky-dory. It can also lead the person to withdraw further, causing himself even more pain or hurt. Along with the patient, the carers also have a changed identity, right? They may be struggling to sustain other commitments to a job or to other needy family members. Their life may be on hold because they put the needs of the dying person first. But the thing is, man is a social animal, and ultimately they do require some sort of social engagement where they feel understood. You might have witnessed caregivers helping each other out in hospitals, striking up a friendship. They do so naturally because of their need to connect and because they feel understood, they feel a sense of connection. So, support groups can really help when it comes to social pain, when it comes to loss of a social identity and a loss of social engagement. Next comes the issue of unfinished business. What do you think this could be? Has anyone heard of this term before? Unfinished business?
Yes, so the unfinished business has to do with my future, me wanting to become a medical doctor, wanting to raise my family. I plan to build houses and I cannot do it again. That is an unfinished business.
Right, absolutely, yes. So unfinished business, as rightly pointed out by Dr. Gregory, I believe, uh, is something which can lead to considerable distress. It can manifest in different ways. It can come up as restlessness, as anxiety, discomfort, guilt, helplessness, so many different ways that it can come out. And it could be about dreams, it could be about ambitions, plans for life, could be anything, right from building their own house to taking care of financial commitments, repaying loans, raising kids. How to identify this? How to identify unfinished business? You just have to keep your ears open and notice. If you hear for patients' regrets, you would most likely get to know about their unfinished businesses. Let's say, for example, you hear somebody saying, I wish I had not stopped talking to my sister. Now, looking back, it seems like such a trivial matter when faced with the possibility that I'll never be able to talk to her again. What does this tell you? That reconciliation, maybe asking for forgiveness, is an unfinished business, and being able to complete that would bring some peace to the patient, right? So, mostly unfinished business would be a major concern in younger patients in their prime who have children who are small, still studying, not settled on their own, or with parents who are aging. So these people's unfinished business would be revolving around their responsibilities as a parent towards their children and as grown-up children towards their parents. And in this context, the most common emotional distress would come from the feelings of guilt, of not being there for them, and anxieties about how the children will cope on their own. Let me give you an example here of a very, very strong patient whom we lost a few months back. I think this example will help illustrate all the 3 points that we have discussed so far: communication, loss, and unfinished business. And it will also help you see what I mean when I say that these factors are all overlapping. They're not really independent of each other. So this patient, she was a lady in her 30s, diagnosed with a terminal illness. So when she was diagnosed, she directly only came to know that it was in the terminal stage, that there was no curative treatment which was available at that point. It was a sudden, shocking news. There had been no indications whatsoever. And she was suddenly faced with a loss of identity. As a young professional, she had to stop working. As days passed and she quickly deteriorated, becoming dependent on others for her basic needs, she could not bathe herself, she needed help to walk to the toilet. There was a loss of dignity, which was especially painful for her to bear at such a young age when no one is prepared mentally for something like this. There was a loss of role. She had two young children, one barely a toddler who couldn't even walk yet, and she couldn't fulfill her role as a mother. Her sister had started taking care of her kids. Her family was extremely supportive. They reassured her that they would take care of her children. So there was no anxiety regarding that per se, but there was the pain of leaving them behind, not being there to see them growing up. It was something she was leaving unfinished. There wasn't much that could be done to help her complete the task, so to say. Unlike other unfinished tasks, like what we saw in the previous example, reconciliation with a sibling is something that is, that has a very simple solution of just making a phone call and letting them talk. But when it comes to something like this, there is no real practical solution, so to say. But what the patient did here was she asked her child to be brought to the hospital. Her elder child, extremely attached to her, 12 years old, a girl, yeah? And she sat with her and told her how ill she was. She explained to her what a terminal illness means, what stage her illness was at, and she cried with her child and told her that she loved her and that she'll always love her. As a palliative care professional, when she told me this, my first thought was that was such a beautiful, difficult, and brave thing to do. But that was not how her family felt. When she was telling her daughter this, her family had tried to stop her repeatedly, constantly saying that she shouldn't be saying things like this, questioning her why she was putting the child through this, etc., etc. That really disturbed her. And she came to me with the question of whether she was being a bad parent by doing this. But somewhere she also knew the answer herself. What she told me was, I know they didn't want me to say it, but it's the truth. I very strongly needed to say it. And the reason why she decided to tell was, one, she didn't want it to come as a shock for her child. And two, she felt that if she hadn't told then, these are her exact words, if I hadn't told then, I don't know if I would have gotten the chance to tell her that I loved her and that I wasn't abandoning her. Here comes the issue of communication. The family, trying to protect the child, didn't want her to know that her mother was going to go. But as research with children of deceased parents shows us, it is best for the child to be involved in and given a choice to say goodbye. The ideal steps to follow for us in this situation would have been, one, to find out from the child what she already knew, picking up on the cues from the atmosphere. Secondly, to help her mother communicate with her. If necessary, reassuring the mother that, that this was good parenting, to give her child knowledge of what was happening. And thirdly, helping her identify sources of support for the child. And she intuitively did all of that, right? This patient's only request had been to help her child through the process of understanding the loss and supporting the child through it. In doing what she did, telling the child and making the request to us, she did indeed take care of her unfinished business to the best of her ability in the given circumstances. And when we validated her decision to communicate with her child, and when we assured that we would talk to her, she could give us a genuine smile. And that was the last I saw of her. Many a times families are not ready to have this conversation. They would rather protect children, but what they don't realize is by keeping them ignorant, we are doing just the opposite of protecting them. We are making them even more vulnerable. They're not opening up doors for them to ask their doubts, to prepare themselves for what is to come, and to ensure that they don't blame themselves, which children often do. So moving on, so far we saw communication, we saw loss, and we saw unfinished business. Next comes a very practical issue, that is financial problems. As we look into a comprehensive psychosocial assessment, we also inquire about financial concerns. Many a times, as people undergo long treatments over years without any money coming in, It drains out much of their savings. Some might be from a poor financial background to begin with. So financial issues is a very real concern. Why are we addressing it under psychosocial issues? Because it is a source of distress for many. It can even stop them from help seeking. There might be fear and anxiety about it, which again means they might not respond very well to our treatment if these underlying causes of anxiety are left unaddressed. So talk about it. For some who have been well off until then, receiving charity or asking for help can be extremely difficult. It can lead to a loss of self-esteem. So what is our role in all of this? One is to talk it out with them, listen to their perceptions, how they feel about taking financial help. Is there something that is stopping them from taking financial help? And secondly, to get them in touch with agencies which can provide aid. For example, at Dilasa, the place where I consult, we have the Cancer Society aid which is available. So the decision makers are informed about it at admission. Again, here it is important that all those involved in the treatment know about this. For example, we had this patient who kept insisting after admission to take him home. The day he got admitted, he started insisting that take me home. Very adamant about it. He had a young son, fresh out of college, who was working. So the nurses inquired with him whether he was not happy with the care he was receiving. Was his pain not being managed the way he expected it? Basically, they were trying to find out what was the reason he so desperately wanted to leave and go. So then we realized that he was troubled thinking about, this is a private hospital and it is going to cost a lot and we can't afford it. And being a proud man, he felt ashamed to share this with the treating team. He told his wife though, and she told her son, and that is how we came to know. Now what the son did was he just kept reassuring the father. You don't think about it, I'm managing it. You don't think about it, I'm managing it. Now this, the patient felt was just a false reassurance. He needed to be involved in the process of financial decision making. Because he had been the head of family so far, he had been the one who was managing all the finances. So he knew the actual position of the family. So once he was told about the aid and how it worked, he was much more relaxed and he was ready to continue to stay in the hospital and to receive the palliative care that he needed so badly. So ensure that you involve the patient as much as possible in the decision-making process, not just in terms of finances, but otherwise as well, because it also maintains their sense of autonomy in their lives, which is very important in a palliative care setting. Next, we talk about spiritual issues. Some of these are social issues and overlap. Now, spiritual well-being is one of the most important influences on quality of life at the end of life. And it's not just limited to one's religion or faith. Yeah, patients may experience a number of spiritual issues, including but not limited to lack of meaning, lack of purpose, guilt, shame, hopelessness, loss of dignity, loneliness. There could be anger towards God, feeling abandoned by God, feeling out of control, grief. So spiritual suffering is a big range of different kinds of distress that you see. It goes beyond religiosity, it goes beyond faith. As one nears end of life, or as one faces the reality of being mortal so closely, they might begin to have existential questions like what is the meaning of life, what is the purpose of life, and with that they might also start to think about the past and question as to what did I contribute so far, what am I leaving behind as I go. Here it is important to help them reminisce, to look at their past trumps, what they have achieved so far. These are ordinary things, but they matter a lot. For example, raising 3 good children, even through difficult circumstances, or being a valued employee of the company that they worked in, all these things. So knowing what they did was valued is what keeps hopelessness at bay and eventually keeps depression at bay. So it is very, very important that we do this. This is a time when reviewing the past can put the present in context. It can be very affirming to the dying person. It may be done in several ways. For some people, just informally talking about it, talking about memories, good memories as well as tragic memories with the family and friends, can very well give them the opportunity to go over, to reminisce, and to receive confirmation from their family that their contribution to the family unit is really, really valued, that they matter. For some others, a more formal life review may be helpful in settling their anxiety and uncertainty. Formal life review processes are available online as well for free. They have been developed in many parts of the world. So you could very easily start using them. It's a set of questions which help the person go back and look at their life very systematically and try and identify what are the things that they actually contributed to others and to their family and to the community. When I say informal life reviews, again, let me give you an example here. We had this old lady at our hospital suffering in a lot of pain actually, and she would keep complaining about it constantly. The entire day she would only talk about her pain and nothing else. And the caregiver, her grandson, for a change, instead of his mother, he came and stayed with his grandmother at the hospital for 2 days. What he did was he sat and reminisced with his grandmother. He started asking her about past incidences when she was young, when she was his age, how she met her husband, all those things. And in those entire 2 days, she didn't once complain of pain, except for when she would be when the nurse would actually go and inquire about her pain status. Even research shows that there is an immense improvement in life satisfaction and reduction in stress following such reviews. Associated with life review can also be a wish to leave a legacy behind or to be involved in planning for the future of loved ones. Some might want to have concrete gifts that they leave behind. It could be anything. It could be a poem that they wrote, or a painting, a sari, or a recipe book, or a photo book, anything. A parent with young children who's dying may wish to leave a letter or an audio or a videotape for the children to keep and to refer to as they grow up. You can help them make these memory books with messages, pictures, other small souvenirs, or something personal for all the things that they would miss. Their child's 21st birthday, maybe your marriage, your graduation, all of these things. So basically any kind of material which concentrates on demonstrating the value of the child or the family members who are left behind for the patient. Reminders of times that they share is highly likely to be greatly treasured. Even if we think of it, just try and imagine that, a lost loved one of yours has left something like this for you, where they tell you how much they love the time they spent with you, how much would we treasure these legacies that they leave us, So yeah, definitely that is something that can be done. It can also give them purpose and meaning in their last days of life. Making a will is another way of ensuring that your wishes continue to carry weight after your death, which is something that we often have to struggle with. Patients are not really ready to make wills, probably because it means that they are accepting that they are going to go. But it is always, you should at least bring up the topic, if not push for it, that they do indeed take legal consultation and make a will. Apart from this, spirituality, very simply put, is being connected to something greater than our own self, being connected to a higher power, right? Not necessarily God, could be anything, not limited to religion, as I said. So assessing a patient's spiritual beliefs, assessing the importance of spirituality in his or her life, exploring if they belong to a spiritual community is something that we need to do. But again, don't assume. Assess if spirituality is important for the person. Don't assume that it is important. And once you have done that, ascertain how important and helpful it is. A simple question is often sufficient. The first question could be, is your faith or spirituality or religion helpful to you? And secondly, how important would you say this is to you? Right? And this could be followed up with, are there ways in which we can support you in your faith? Or can we help provide you with something, provide you with some facilities to support you in your faith? Right? So for example, again, a patient in the Lhasa reported that he used to visit a local temple every day evening. And that was a part of the social fabric of his life as well. That is where he met his neighbors, his friends. He would spend some time there, pray, and then come back. So when we inquired if he had noticed when he was brought in the hospital that we had a small place of worship in the hospital right at the entrance, he said yes, but he was bedridden. Okay. And we asked if he being able to go see the idol in the evening and sit and pray there for some time would help in any way. He said yes. It was just a matter of arranging for a wheelchair to take him to the next room. It had never occurred to him that he could ask for it and that the hospital staff would be willing to do something about it, because coming from the background that he did, he had no clue that his spirituality did actually matter in the entire scheme of things in the palliative care setting. For him, it was a hospital. They were going to take care of his pain, and that was it. So often you need to bring it up. You need to ask the patient if you can do something. So interventions need not be complicated. They need not be about super brain science. Mostly they just need to be compassionate and humane for them to work. How does this help? How do these spiritual interventions help? One, for those who believe in it, concepts like transcendence, soul, liberation, reincarnation can help patients deal with time and make meaning out of it. It can also help reduce suffering and facilitate acceptance of the situation. Now, this can act like a buffer against distress, particularly hopelessness, helplessness, loneliness, depression, and death anxiety. Transcendence, a belief in a higher power beyond human existence, basically enables connectedness. It removes the isolation of suffering because it sets it within a larger landscape. And if you go to see, the religious traditions across the world have their own interpretations of suffering, and many also have practices which enable people to transcend their immediate selves through prayer, through meditations, through rituals. And as they acknowledge the reality of suffering and death, these rituals often point them towards fulfillment of the human soul beyond suffering. Even for the family, if you go to see rituals following death, which again we have in all cultures across the globe, these rituals is how the family makes sense of their loss. These acts of remembrance can actually aid in processing their grief. But again, although they are very helpful, make sure you're not letting your own beliefs interfere or assuming that the patient also has similar beliefs. Let's not push the patient in any way to engage or to not engage in spiritual practices. Our job is to respect the patient's spiritual orientation or a lack of a spiritual orientation, and to encourage spiritual practice only if a person is already engaging in it or would like to engage in it, not to push those who do not. So ensure that patients are given the opportunity to express their spiritual beliefs and practices. Moving on to grief and bereavement. Grief is the emotional response associated with loss. It's an inevitable dimension of our humanity. At the same time, it's an adaptive adjustment process. It helps us deal with the change, and one that can be approached with courage if proper support is available. Again, intervention is not always warranted in all kinds of grief. For the majority of people, although bereavement is painful, their personal resilience will ensure that they adapt normally to the entire process. So there is no justification for routine intervention because normal grief is not pathological. So So as the patient and family journey through palliative care, we can see the clinical phases of grief progressing from anticipatory grief to through the immediate news of the death to the stages of Let's first look at not to pathologize. In case of normal grief, you would see emotional waves of distress. You would see unavoidable crying, preoccupation with thoughts of the deceased, reduced concentration. You could also see other somatic symptoms like restlessness, numbness, weight loss, fatigue, and also behavioral symptoms like social withdrawal or constantly seeking consolation from someone. Here, we just need to be a supportive presence. Let them know that we are available to help if they ever feel the need. Sometimes active intervention is required when we see some abnormal patterns. Anticipatory grief is what precedes the death. It results from the expectation of that potential loss. Now, common difficulties that can come up with anticipatory grief. One is impaired coping, where the family members might deny the seriousness, or they might withdraw from treatment, or they might not be involved or show anger towards the treating team. Our role is to encourage them to express their feelings openly, to help them recognize that saying goodbye is a process with opportunities to celebrate the life of the patient in the way, to express gratitude, to take care of unfinished business, and to reminisce. When we talk about complicated grief, this represents a pathological outcome involving psychological, social, or physical morbidity. It is often seen as prolonged grief with difficulty accepting the loss, meaninglessness, which goes beyond 6 months or more after the loss. And this is often associated with poorer physical and mental health outcomes and suicidality. And this is when active intervention is required. Inhibited or delayed grief is also a form of complicated grief, an avoidant form, which is where you see a person who apparently appears to be dealing quite normally, who doesn't really express grief after the passing of the patient, and the grief comes after a delay, after a phase of normality. It suddenly hits. That is what we call inhibited or delayed grief. And there is also what we call as disenfranchised grief, which is also what we call the hidden sorrow of the marginalized, for whom there is less social permission to express the dimensions of loss. Say, for example, extramarital relations or homosexual partners, where there is not much acceptance from the society for them to express their grief. So that is what we call disenfranchised grief. Complicated grief is more likely when there is untimely traumatic death, when there is a lack of support systems in place, and also when there are previous vulnerabilities which exist, or in case of dependent relationships where the caregiver was overly dependent on the patient, or vice versa, the patient was overly dependent on that particular caregiver. Moving on to psychological issues, purely psychological issues. Of course, we know the common ones. We know anxiety, we know depression, we know body image issues, especially pertaining to cancer, where you see loss of attractiveness, where the sexual needs are not being met, and also somehow connected to issues of self-esteem and self-worth. But instead of going into it one by one, we can put it all under the umbrella term of distress. And how do we define distress? It's basically an unpleasant emotional experience of a social or psychological nature, which is tied to, which interferes with the ability to effectively cope with the illness and illness-related treatments. Now, making of a psychiatric diagnosis and the rapid identification of patients in need of help are difficult for many reasons. One major problem is that psychiatric symptomatology may often be mimicked by the side effects of medication or by the disease process itself. And that is why underdiagnosis and underidentification is highly prevalent in palliative care settings. This link, which you can see on the screen, is something that I'll of course be sharing with you. It's a very helpful video on how to diagnose these psychiatric issues without, getting caught up in the somatic symptoms and getting confused by them. Just to briefly throw a light on it, here in this table also, you can see the key components of how to diagnose major depression, anxiety disorder, and adjustment disorder, the three most common psychiatric problems that we witness in a palliative care setting, along with what you need to rule out. The rule out considerations is what is extremely important here, right? So you can always, again, this is also going to be shared with you, so you can definitely keep referring to this whenever you need. Since we are short of time, I'm not, reading it out and explaining it all to you, because I'm pretty sure you are at least familiar to an extent to all these three conditions. As I said, underdiagnosis and underidentification is become a problem, mainly because it's not being recognized by professionals. So being able to identify and assess is very important for all of us. In a drive to address this in the context of cancer care, specifically the NCCN, which is the National Comprehensive Cancer Network in UK, they came up with, they have promoted development of brief rapid screening tools for distress, which can be administered by any professional, need not be a specialist. So your nurses can administer this, your interns can administer this, you can administer this, not an issue. So the distress thermometer is something which is very, very useful, which gives you at least an overview or a screening of psychosocial issues that the person might be facing. Depression is what frequently remains unrecognized and untreated, because often we dismiss it as normal reaction, even in the face of severe affective disturbances. And the most common diagnostic difficulty which arises in the palliative care setting is how to interpret the physical or the somatic symptoms which patients present in the context of a possible depression. The challenge here is to determine whether these symptoms are part of the depression syndrome or are they a direct biological result of advancing illness, especially cancer, and to focus on the non-somatic classifying symptoms like inability to access past good memories, which will often happen in clinical depression. Or let's say, for example, in depression, you would often see that the self-image changes significantly, whereas if it is grief or a normal reaction to the illness, you won't see that the self-image is changing. Or if it is grief, the patient will be readily responding to comfort or care, and they would be able to enjoy pleasurable activities, and they would value authentic connection, which will be lost if it is clinical depression that you are seeing. Again, so it is always better to be on the safe side, to be suspicious and to refer to a specialist. Occasional thoughts of suicide are also quite common in palliative settings, but if there is frequent persistent presence of these thoughts, that would indicate the presence of a psychiatric complication. Many a times, if these are fleeting thoughts, if they are not persistent, when we are assessing the risk and intent, all we need to do is acknowledge their need for control over death. That is all we need to do. If it is non-suicidal or fleeting thoughts of suicide. Here, nursing staff have an important role in identifying patients who may have psychiatric symptoms, because they spend more time in direct patient contact. It enables them to observe behavior more closely, and the nature of intimate nursing tasks also gives them an opportunity for patients to express any psychological distress. So make sure you're talking to your nurses, because they might not be able to identify specific disorders, but they're definitely skillful in recognizing distress when they see it. So how can a doctor or a nurse who is working in a palliative care unit establish that a patient is depressed and requires treatment or further assessment? There are a lot of preliminary screening tools which are available, like face scales or distress thermometers. Apart from that, there are also rating scales, clinician rating scales, like the caregiver burnout scale or BDI, that is Beck Depression Inventory or Edinburgh Depression Scale, etc. Again, it's about gauging the emotional temperature of the person, but it's not possible to make use of these in a generalized manner. Not all depression scales are applicable in palliative care settings. So not all are valid, not all screening tools are valid, so not all can be used. The ones that I've mentioned here on screen definitely can be used. So use these scales with discretion. In case of palliative care, many times the patients might be unwilling to or unable to discuss symptoms. So research shows that asking caregivers instead of the patient is what we often do. If the patient is not responding, we would take the same clinician rating scale, we would go to the caregiver and we would ask them, are you observing that they are being socially withdrawn? Do you see that do they have crying spells, etc., etc.? But the research shows that in case of palliative care settings, asking the caregivers is extremely unreliable. Their ratings are closer to their own distress instead of the patient's distress. It is colored by their experience and their perception of the illness. So please be aware of this when you are doing a screening. Just asking, are you depressed, sounds unreal, but studies show that this simple question is one of the most reliable predictors of clinical depression in the palliative care setting. So it's always helpful to assess at admission, but along with that, also, always keep an eye out for appearance of new symptoms, just like you would for a physical symptom. So all members of the healthcare team can observe and can subjectively report distress that they feel is psychological in nature, like fear or anger, or psychologically mediated distress where you see pain or breathlessness. This may or may not meet the criteria of a discrete psychological disorder or a diagnosis, but regardless of the etiology or the diagnostic label, it is ultimately about the patient's subjective distress and we need to help with it, right? So it's always important that whatever psychological distress is reported. And our work is not only to identify problems and distress when it comes to psychological issues, it is also to see and to help our patients see their current support systems, which can help with their social distress, and also their internal personal resources and their coping strategies, which are their strengths when they're dealing with this or going through this journey. So here are just some final pointers about what your patients need. The psychosocial aspects of care of the dying person, regardless of the diagnosis, includes the need for understanding of symptoms, of the nature of disease. Secondly, acceptance, regardless of their mood, regardless of how sociable they are, regardless of their appearance, acceptance. Self-esteem, which, what we said about giving them a sense of autonomy, involving them in the decision-making process, making them feel safe and secure in the place that they're being treated in. A feeling of belongingness, a wish to feel needed, to not be a burden on the family, and love, definitely, expressing affection, getting some human contact, spirituality, which we have already spoken about, being able to express their spirituality and explore their spirituality, and hope for an improvement in any aspect of their life or of their living, not necessarily hope for a prolonged life. It can also be hope for improved quality of life, as we all know. So in the provision of psychosocial care for people at the end of life, each of these needs must be identified and addressed. And finally, here are some do's and don'ts. Definitely be honest and trustworthy with your patients. Respect their right to make their own decisions. Keep aside your own biases. Make it clear to affected people that even if they refuse help now, they can still access help in the future, and ensure confidentiality unless it is to do with fatalities and safety of the individual or others, and definitely provide factual information. Please don't make false promises, give false information. Don't pressure people into telling their stories or judge them based on their actions or feelings. Definitely a strict no. Don't talk about your personal issues or troubles. Don't tell them how hard you also had it. Don't make comparisons. Don't philosophize or preach or impose your perspectives onto them. Um, and ultimately, just, as you see, most of these needs, most of these do's and don'ts are not about you being able to provide technical therapeutic expertise. You will definitely have clinical psychologists and psychiatrists on your team for that. It is just about being a non-judgmental, compassionate presence who is witness to their suffering, who is giving them space to express their distress, and who is accompanying them on their journey, trying to help add life to their days, not simply days to their life. Thank you so much. And if there are any questions, any doubts, please go ahead and ask. I would be happy to answer them to the best of my ability.
Thank you, Ms. Mukta. Thank you so much. Realizing and accepting that psychosocial support is definitely not a topic to be covered in a 1 hour session. It is now up to the audience whether you have any inputs to share. Yes, Dr. Nari.
Ma'am, I just wanted to ask, when should we start assessing these issues with the patient? Should it be on first meeting them, or wait for a couple of meetings when they're more comfortable with us? How do we go about, ma'am?
That's a very subjective call to take. It can differ from patient to patient. There might be some who are in extreme emotional distress when they come to you, and that might definitely not be a good place to start. So, as you said, you would give them some time to build some rapport, to get a little more comfortable with the setting, and then get into the assessing part. And for some, you might just start right at the first time that you meet them. But when you talk about assessing, it need not be formal assessments all the time. Even the first time that you meet a patient, just observing. So, just the way it comes naturally to you, that when you see a patient, you know what physical factors to look for, what physiological, tick boxes that you have in mind. Similarly, when you're in a palliative care setting, you'll also have a list of psychological check boxes in your mind, where you would just observe the patient, and then from there you would assess whether a formal assessment is required, or do you just directly ask for a person from psychology to come in and start. Yeah.
Okay, thank you.
But when we speak about so things like the distress thermometer, which I had shared, that is something which is often used as a routine practice in many settings, in many of the places, even the places where I've worked in. Distress thermometer is something which is used regardless of whether you see or whether you observe a person having a subjectively you observe them having some distress. It's a routine thing.
Okay, it's part of your assessment only.
Yes. Yeah.
Okay, got it. Okay,
Yeah.
thank you.
Yes.
Do we have any? Okay. We have one comment coming up from Dr. Muhammad. There, all the time we offer psychosocial support depending upon how he took the situation in his or her mind. So there needs some sort of sense how we help one by his or her mind strengthen. Dr. Muhammad Khader, if you would like to throw more light on your comments.
Sorry, I cannot hear you properly because there is a network problem is here.
No worries. I just
So
wanted to
please
check
repeat.
if you wanted to throw more light on your comment. You wanted to add something to that.
Yeah, I want to add something because in his psychosocial support, when one is feeling sick or stressed, so three of things like one thing, once however he or she took the situation in his or her mind, then another one, how he or she took support from outer side or other purposive way, like from medication, from psych counsel, or from other psychotherapy. So there is a lot of things going needed that time actually. So how we can actually strengthen her or his mind to make the situation easier. So this is my understanding. I wanted to know from the facilitator because I had a lot of things. So if it will be more useful, I think.
Okay, okay. I understand your question, sir. It's you want to know about how to reinforce their own personal resources to cope with the disease. Yes.
Yes, I think so.
So-
Like he wants to know what we can do to enable the
What we can do,
person.
right.
Yeah,
Right,
actually like
right.
that. Actually like that. Yeah.
Right. So on your level, I think as palliative care practitioners, you can definitely, giving them some space to vent out is also enough, because most of you might have heard of catharsis, where there is, when the person is able to take out the emotional distress, even that is really helpful for the person to gain some hope and some personal strength. Apart
Yeah,
from that, when you speak of specific techniques to improve resilience, that is what the psychologist or the psychotherapist takes care of.
Yeah.
Depending on what the condition is, they would be helping them strengthen their own personal resources.
Yeah. So we can actually added him some support for psychotherapist or counselor or psychosocial
Yes,
expert for
yes,
this. Yeah.
definitely, yes. Because that is, I think it's also mandatory in a palliative care setting. You need to have a clinical psychologist on board who can take care of these issues.
Yeah. Thank you.
Any other questions?
Yes, hello. Yes, ma'am.
Yes.
Yeah, thank you very much for the presentation. So educative. So my question is like having to do with a lot of psychosocial issues. For example, when it comes to finances, you have a lot of patients that becomes much more distressed when it has to do with financial issues. One,
Right.
monies to take care of medical bills, monies to feed the family, and like more so when the person is a breadwinner. So, as a psychologist, so how would you tackle some of those problems there?
Yeah, so that's what I had mentioned, sir, in the presentation as well. We have these various agencies. No, this is something which actually comes under the work of a social worker, if you have one in your setup, where they would get them connected to these agencies which can help with the finances, can provide financial aid to these patients.
Okay, thank you so much.
Yeah. I hope I answered your question.
Yes.
Okay. Yeah.
Yes, adding
So,
to that, basically palliative care, the entire concept of palliative care is the working of a multidisciplinary team, wherein you involve professionals from all aspects like doctors, nurses, the social workers, all together in case of the patients, so that things don't stop or things don't get delayed and things more smoothly for the beneficiaries all along.
Right.
And we have one query from Dr. Smita. For psychosocial issues to be handled, who would be mandatory on the team? A psychiatrist, psychologist, psychotherapist, anyone else?
Okay. As per my understanding, as of now, if you are speaking about the legalities of it, it's a clinical psychologist that you need. specifically an RCA registered one. Mainly because they are trained in terms of grief work, and they're trained in terms of, you know, a little bit of health psychology, behavioral medicine, all of those things. And mainly because, see, a psychiatrist, when you talk about them, psychiatrists are basically, they would be able to prescribe medications, which also your patients might need. But when we talk of these psychosocial issues in the palliative care setting, most of them are going to be the ones where you would need some sort of therapy rather than medications. Medications would come into picture only if there is a clinical diagnosis, if there is depression or anxiety or an adjustment disorder or something like that.
Thank you, Ms. Mukta. Dr. Smith, I believe that answers your query. And we have one more coming from Dr. Anish, a question from Dr. Anish. Many times a patient is advised by family members, and many times it can be wrong advice. For example, like go see a Baba, some miracle worker, etc., which can turn badly. So what can we do to reduce such unnecessary involvement of relatives and friends?
There are definitely limitations to the kind of work that we can do. But definitely, you know, if you've established trust with the patient in the first place, they would definitely come to you when such advices come, you know, and discuss it out with you. And this is where the initial family meeting will come into picture. You know, at admission, you generally have a family meeting with the with those who are with the patient and those who are involved in the decision making process, where you explain the prognosis, what you're going to do and all of that. So that is where I think these things can also be addressed.
Dr. Anish, I believe that answers your query. We are like ahead of time right now. So, Mukta ma'am, with your permission, if
Sure.
no one else is having any queries, we are quickly moving to the case presentation. In case you are having any queries, please do feel free to put in the chat box. We'll take it up after the presentation. Dr. Jyoti?
Am I audible to everyone?
Yes, perfect. Please go ahead.
I am Dr. Jyoti Sharma. I am senior resident working in Department of Radiation Oncology at IGMC Shimla. So I'm presenting a case of 69-year-old male patient with the diagnosis of CA oropharynx. The TNM staging was T4A N0M0. It was a locally advanced stage 4A. Presenting complaints were difficulty in swallowing and cough with expectoration. In the history of illness, he was apparently well about 3 to 4 months back when he had history of difficulty in swallowing food. There was a history of occasional pain in throat while swallowing, which was mild to moderate in intensity. He had history of cough with expectoration. The sputum was white in color, thin in consistency, and non-foul smelling. He was afebrile, and there was no history of noisy breathing, no history of vomiting or blood in the vomitus, no history of abdominal pain, no history of shortness of breath, no history of chest pain, no history of blood in sputum. In the past history, he was a known hypertensive and diabetic and on medications. There was no history of ATT intake, no history of any major illness in the past, surgery in the past. Personal history, he had a mixed diet. He was a smoker, about one BD bundle per day for about 50 to 60 years, and occasional alcohol intake was there. The family history was not significant. In examination, he was conscious, cooperative, well-oriented to time, place, and person. General physical examination was within normal limits. In local ENT examination, oral cavity, he was a dentalist. Oral hygiene was well maintained. Tongue protrusion movement was normal. There was no deviation. Oropharynx, the anterior tonsillar pillar was normal, but there was an ulcer of proliferative growth, which was visualized as well as palpated behind the posterior tonsillar pillar. The posterior extent of the growth could not be reached. In DL examination, which was done in the ENT department, there was an ulcer proliferative growth in the left side, the vallecula, and the biopsy was taken. treatment and significant investigations. CT neck was performed, which showed a proliferative new growth involving tonsillar pillars on the left side with thickening in the aryepiglottic fold, which was suggestive of supraglottic extension. The biopsy report came out to be moderately differentiated squamous cell carcinoma. X-ray was done as a part of metastatic workup, which was normal. CB-NAT was done for sputum, which was negative. Routine blood investigations were normal. KFT, LFT were normal. Then further, we made a diagnosis of CA oropharynx and he was planned. In view of a 69-year-old male patient T4AN0M0, which was a biopsy-proven squamous cell carcinoma of oropharynx, stage 4A, patient was planned on chemoradiation. The dose prescription can have the previous slide. Yeah, 66 gray, 33 fractions, 6.5 weeks. This is the dose prescription which we radiation oncologists prescribe. It was done with the help of by 2 parallel opposed neck fields and weekly cisplatin. So chemo as well as radiation, CRT was planned. Next slide, please. Now the psychosocial aspects of the patient. Patient is a retired government employee with a vast ancestral property. He is having one wife and a son and a daughter. Son is aged 38 years, daughter is 45 years of age. His wife stays separately as she works as a PN in some school in a rural area. He has a very rigid mindset and he has disowned his son from his property as he married girl out of his choice outside the caste. His daughter is a widow with a meager income and 2 small kids. As the cancer treatment will last about 6.5 weeks, there was no permanent attendant with him. Hence, the supportive care from the family during the cancer treatment to cope up with the radiation-induced toxicities, the loss of appetite, low mood, nausea, vomiting. It's difficult to deal with it. His daughter was with him for about 4 weeks, but he also fights with her, and then he didn't listen to her. And even one day they come and there was an incident when he injured her by throwing some utensils on her, and she left him mid-treatment. His wife and son attended him only once, and they all started and created a scene in the OPD itself. Next slide, yeah. Patient had the known radiation-induced toxicities in the second week of treatment. He was prescribed symptomatic treatment like oral hygiene, then benzidamine mouth rinses, paracetamol 500 milligram TDS, then B-complex iron supplements. However, the intake decreased mid-treatment. He also had bout of herpes simplex over the lips and angle of mouth, for which the antivirals were given, and the treatment had to be stopped for about 10 days. In the 4th week, the renal functions got deranged owing to the inadequate hydration and also the cisplatin-induced, in the toxicity of cisplatin. No attendant was present and cisplatin was hence omitted from the treatment plan. In the last week of treatment, there was no one to accompany him only, and hence there was a break for another 5 days. Finally, the patient completed his treatment and was sent home and asked to come for follow-up with the supportive medications. He was prescribed supportive medications for about 2 months, like Hematinix B-complex, oral gargles, and since he was complaining of pain, he was given tramadol, mouth-dissolving tablets for pain relief, 50 milligram TID. The main concern here is that despite no financial constraints, since the patient being a retired government employee, but there was no attendant accompanying him, there was a break in the radical cancer treatment multiple times, which may hamper the local cancer control and overall survival for him. The chemoradiation may lower the immunity of the patient, and decreased intake adds to it. So the lower immunity must have led to the herpes simplex in this patient. And this must be an added concern because it's quite painful and itching is there, pain is there. And so it must be an added concern in an already suffering cancer patient. Now, cancer treatment is in itself a very big challenge because there are n number of side effects are there, like nausea, vomiting, decreased appetite, hair loss, and we need continuous encouragement and immense support from the family and friends so that we are able to complete it. And the family disputes as they were going on, but it added to the ongoing misery. So to summarize, he's a 69-year-old male patient, diagnosed case of CA oropharynx, treated with a radical intent with chemoradiation. Patient had treatment tolerability issues, poor family support, leading to frequent treatment breaks. And we also anticipate that in the follow-up also, he might take a break or he might default in the near future. The points of discussion. As a primary doctor treating him, how much should we intervene in the family disputes which are hampering the treatment which is prescribed by us? If any untoward happening occurs during the course of treatment and no accompanying attendant is there, what is our responsibility medico-legally? If the patient is non-compliant towards the special instructions given to him during the course of radical treatment, how can counseling help? How should we treat an angry, yelling, crying patient who's refusing treatment due to the family issues? The wife is not turning up, the daughter has gone away because there was a fight. So multiple times he was alone most of the time. So how to balance the intention to radically treat the cancer on one end versus respecting patient's autonomy, because he was saying no to treatment many times during the course of treatment, course of radical cancer treatment. Then how to prevent the breaks in the further routine follow-ups, or preventing the loss to follow-up in this patient? Can the family counseling help? Are such sessions fruitful in the patient with minimal education or low socioeconomic status? Inability to tolerate a radical cancer treatment often leads the patient to opt for alternative medicines and seek help from quacks, the quackery or the babas, which someone was talking about. It further deteriorates the chance to cure. So anything that can be done to halt that. Next slide, please. Thank you.
Thank you, Dr. Jyoti Sharma, for that elaborate case presentation. Now, before we move on to the comments from the faculty, would any of the participants like to share their inputs, their thoughts on these discussion points? Yes, Dr. Anish.
Hi. Can you hear me?
Yes, yes.
Yes.
Yeah. So many a times we deal with such patients in ICUs, and there was a time when there was a psychiatric patient came with injury, self-inflicting injury to his neck, and ended up being taken up for emergency surgery, and later had a tracheostomy. And the relatives were similar like this. That was a young patient. It was a 28-year-old patient, unmarried fellow with a schizophrenia diagnosis.
Mhm.
So such incident happened, and the question, the doubt which I asked, how to decrease the involvement of relatives in quackery and things like that, is actually from this clinical experience which I had. So we that time I think it's a similar background. So that time we tried giving a family counseling with the daughter and the wife, and even instead of like in this case, instead of like keeping the patient with us, if it is possible for the patient to move with the wife in the place where she's working and get treatment from somewhere in that area, such options can be given to the patient, I think. And also counseling has to be given to the son and the daughter to give enough support for the patient. And many a times these relatives only will blame the patient for such a disease. They will obviously tell and blame him for smoking so much, and that is the result, and it is the thing that which you brought on yourself. Like that, blames can happen. So I think family counseling is one of the most important factors. Like Madam also told, the first sitting with the family is very important. And I think that is a main point over here, family counseling. And even giving a spiritual awareness for the patient with if he is a religion, I mean, is a believer in some kind of God, and I think it can also help in such instances. That is my point. I mean, that is
Anish,
what I want.
you did the counseling yourself, or you took help for with some clinical psychologist or psychiatry people?
Clinical psychologist also. But unfortunately, in the clinical experience that I had, with this patient. Actually, with the psychologist also, it was failure because this relatives were not at all helpful in supporting the patient, because he obviously is a schizophrenic and he had many breakouts, psychiatric events at home, and many times he has traumatized the relatives, and they were not willing to help, and they were telling that he should be taken to a psychiatric center and locked up, and immediate relatives are not willing for that, which resulted in a self-inflicting injury. So that's what happened, and it was not helpful. Eventually, the patient succumbed to severe infection in the throat because it was a vegetative injury that he used
That's what
some.
I'm worried about, that he might default in the further follow-ups, basically, because of the poor family support.
That is an unfortunate truth in our society, that many patients happen like that. So that is my input.
Okay. Thank you, Dr. Anish.
Thank you, Dr. Anish. Dr. Newstar?
Yeah, hello, good evening. Ma'am, thank you so much for taking us through. I believe it is a very vast topic, and thank you for introducing us to this aspect. Actually, it's not a question, but it's just a comment that I would like to make. In the sense, in the past few weeks of attending these sessions on palliative care, what I've come to realize is these psychosocial issues which we are discussing about. These are, I think, most of the time, at least in my practice, these are some of the things which I neglect them totally, and probably these are the issues which directly and indirectly plays a lot of role in the management of the patient. When ma'am was sharing about this particular case as well, when she was talking about so many issues which is psychosocial issues that this patient is dealing with at this point of time, and it is definitely directly hindering the treatment process of this patient if they are not addressed. And another point I would like to make, ma'am, is no, during my work in some of the places that I've worked with, I've seen a social worker working, I've seen clinical psychologists working, but I probably these are the people where probably we have at least I personally have not understood their value until having listened to this session today. I understand that there are a lot of role which we can keep them involve them, and especially when they are on board together as a team, I think it would even be much more beneficial in planning treatment and helping tackling issues of these patients, ma'am. So thank you so much.
Thank you, Dr. Newstar. Dr. Arnab, further to commenting that we can discuss the consequences of disowning the son or getting angry at the daughter to the patient, wants to know what is the expected outcome that patient wanted with his behavior, and what has gone wrong in the real scenario. Dr. Jyoti, would you like to take that?
Just, what is the expected outcome of the patient wanted with this behavior? I mean, he was a angry old man basically. So he must be his inherent nature. You can't change anyone's basic nature, and with the age you can't actually. He had a very rigid mindset kind of thing. We wanted to help him out, but he was not ready to take the help. Somehow I used to counsel him, and that's why he was able to complete the treatment as per se. But still, I don't think he has a good relationship with his wife, son, or daughter.
Thank you, Dr. Jyoti. Yes,
Yeah,
Dr.
hello. Hello?
Yes, Dr. Grigory, please continue.
Yeah, thank you very much. So for me, I think it's not done for the relatives to abandon the patient, even though the patient might be very harsh. So few things we have to take into consideration is that the patient is already depressed, owing to the fact that he knows he's gonna die. That is one thing, and probably he's not accepted it at the moment. And then he's old, so old age could also come in So I think one of the things we have to do is to basically engage the relatives to ensure that they understand him very well. I'm sure this is not the first time he's behaving this way. Probably it's been part of him ever since. So I think it's for all of us to talk to the relatives to understand that this is the situation, and then they have to be very much mindful of how to deal with him and to bear with him. That is what I think.
Thank you, Dr. Gregory. Yes, Dr. Shalin, our faculty, Ms. Mukta, is completely in agreeing with you that clinical psychologists are very few and far in between our country, in the entire country, and hence we often end up taking help from psychologists who are not trained adequately with these issues. Moving on, we have comments coming in from Dr. Manjari, who says that there is surely no one-stop solution to family disparities are from the past and some unrelated to illness. Immaturity amongst family members, with each one having multiple issues, is not an easy situation to deal with, even with psychologist help. Yes, definitely. And Dr. Shalin Kumar further comments that what is unfortunate is getting drugged by psychiatrists as a quick fix solution. And yes, Dr. Aisha, you would like to add something?
Here in this case, it was the basic family issues which was the main concern. And however, what the daughter and son were reacting to something else which happened in the past before he was a patient. So in such cases, like Dr. Anis said, the family counseling is the most important thing, and it cannot happen overnight. The change in the attitude of the son or daughter or their family issues cannot be sorted out in 1 or 2 days. So in meanwhile, there should be a provision to admit such patients in some care under the hospital, wherein his nursing care and all his radiation reactions or nutrition, everything could be taken care of. So that was my.
Thank you, Dr. Aisha. In best interest of the time, now I hand over the podium to the faculty. Ms. Mukta, over to you for your comments.
Yes, thank you so much. First of all very, very, great inputs, I should say, from everyone. There are a few points I'd like to make here. First of all, a very practical suggestion. I don't know if it's possible in your setting, but some of the hospitals do provide caretaker services, especially considering that he doesn't have any financial issues. So if having an attendant is going to change the treatment course, then I would suggest that you put it across to the patient and see. Secondly, since you say that the patient himself is not really willing to go ahead with the treatment, or treatment compliance is very less, here you should definitely get in a CP at this point. Whenever you see that there is no treatment compliance, get in a CP. Because then so ideally, if I was called, what I would do in this situation is, first of all, I try and find out the reasons why he's refusing treatment. There could be many. We can't assume. We often end up assuming, and it's always better to actually talk to them and find out what are the reasons. And secondly, help them make a pros and cons analysis so that they take an informed decision, whatever that it is. And then if after all of this, he still is refusing treatment, that's a personal choice. We cannot, that's where we set the boundary. Where we cannot be intervening any further. Yeah. So, and another thing is, in the last, I think, last slide, whatever, I spoke about acceptance, where the few things that your patient needs, regardless of what they're going through. Unconditional acceptance is something that is really important here, because when I say unconditional, despite of his sociability, his attitude towards you, his attitude towards his family, he might appear to be a very rude, arrogant, hostile person. But as long as you're accepting, it reaches that person that you are accepting him regardless of him throwing a tantrum, and that can often lead to treatment compliance. because you just need to give them time to settle down, and then they are ready to listen to you. So that goes a long way. And family therapy, yes, as many of you have suggested, family therapy definitely can help regardless of their educational and socioeconomic status. That can definitely help. Another thing which needs to be done here is putting things into perspective when it comes to the family disputes versus the illness. You just need to put things in perspective, as in what I had, the example that I'd given in the unfinished business part, where just in terms of when you're facing actual mortality, how important are these disputes to you, and what do you want to do with them? That is something that needs to be addressed. And talking about QEX, that's a major issue, I think. And but there is one simple tip which might not be a short solution, so to say, but it can definitely make things easier for you. So what happens is, when a patient or when family members are talking about QEX or going to these babas and all these other things, we instantly tend to get, sort of authoritarian. We tend to tell them that it's wrong, that they should not be doing this, that they would regret it and whatnot. So definitely put across your point. I'm not saying don't. Make it very clear what you feel about it. But before that, make sure you're validating their feelings behind their actions. There's a reason why they want to go to the Baba. Because they're feeling helpless, because they feel everything is out of their control, because they want to try everything that they can to save this person. So validate that feeling. Don't validate the action. Don't say that what they're doing is right. Make sure you understand what they're feeling and that you convey it to them. Because when you do that, it's going to be like, otherwise they feel ununderstood. They feel defensive. They'll instantly go up against you. So the moment they feel understood, the moment they feel, हाँ doctor को पता है मुझे कैसे लगता है, why am I doing this? Then they're more likely to actually listen to what you say. Yeah, so I think that's it from my end. If any other doubts you want cleared about this particular case,
Ma'am, I was able to counsel him to at least complete the treatment part, but now I am worried that he might be losing further follow-ups.
Right.
So
right.
because of the family support, as I told you, the entire story.
Right.
What can I do then? Like, so that he doesn't, he's not lost to follow from my end. Because he has at least completed the whole treatment part somehow, though there were breaks in the treatment and everything. But I don't want him to lose the follow further.
Right. Here I see, again, there are limitations to what we can do, how much we can do. Considering that it's an adult person that you're dealing with, you're no one to actually make their decisions for them. The most you can do is advise as to what you think is right from your perspective. And then, so here in this case, you can definitely talk to the wife as well as the patient about why the follow-up is important, that it's part of treatment. It's not, it's not that the treatment is over and then there is a follow-up. Make sure you're making sure that it's part of treatment.
Correct.
And then it's up to them. It's not, you can't really interfere after that.
Thank you.
Yeah. I know it's hard to, sometimes just let go when you know you can do something.
Exactly.
Yeah.
Before we wind up for the day, there are some, I should say, professional tips from Dr. Arnav. If you were to die tomorrow, will you have any regrets? Is one question he usually asks, and then we can explore what all can be done to change that. And Dr. Smita suggests that a documentation of the efforts made are important, as if treatment is discontinued for any reason, there is evidence of that discontinuation happened because of the doctor. So I believe there are no more questions for the day, no more comments or inputs.
I
Thank
just
you.
wanted to say
Yes.
one thing. Yeah,
Yes,
just
yes,
it
please.
was wonderful to have such an interactive session today. Thank you so much.
Thank you, Ms. Mukta, for joining us. Actually, we should be the ones thanking you because you put at least some light on the unexplored area of the psychosocial aspects, in especially in the palliative care field. And I believe that everyone would have got at least one new idea, one new perspective of the topic from today's session. Thank you so much. We do know that this is towards the day end, and you might have had a very busy day, and still you found out time and was patient enough to answer all our queries. Thank you so much for that. And with that note, this is Sri Priya along with Ms. Mukta signing off from the Tips Eco Hub. See you in the next session with another interesting topic. Till then, everyone stay safe, be happy. Take care. Bye bye.